Hello everyone to Nextillo. The wonder has a name. Let's take our class on anesthesia today. I am Dr.Jyotika Kumar and we'll be taking our session on pre-operative evaluation before we take up any patient for surgery. Before starting our lecture, let's thank Dr. Sunil for giving us this opportunity, and we're very grateful to him to have let us come forward and help students like you. All right. Now, once we take this lecture, in the end, we'll be having a sort of a quiz and a question of the day. The person who answers the question first and is the most quick in giving us an answer to the question we have a surprise for that student. All right, now let's begin our lecture on pre-anesthetic evaluation. So what exactly is pre-anesthetic evaluation and why do we need to do it? Any patient that we take up for surgery needs to undergo an evaluation so that we know what risk the patient might have for anesthesia. We need to know about whatever comorbidities the patient is suffering from and whatever the treatment that patient is on, so that the treatment he is taking can be modified or stopped accordingly. And when we assess the patient like that, we know what risk anesthesia can have on him and whether the patient will tolerate anesthesia. Once we know all this, we will be very easily to assess. We will be very easily be able to plan our action. We'll be able to take up the plan of action, whether we want to give general anesthesia to this patient or regional anesthesia to this patient, or any other anesthesia like local anesthesia, or certain kind of blocks that are there which come under regional anesthesia again. So this is about what needs to be done and why it needs to be done in pre-anesthetic checkup. All right. Now, in the pre-anesthetic checkup, we take up a detailed and focused history of the patient. Whatever is valuable to us, only that we ask in history, like whether the patient has had any previous surgery and any previous anesthetic exposure, whatever allergies the patient is suffering from, so that we avoid those medications, and what surgery the patient has come for now, and so that we can plan an appropriate anesthesia for the patient. Further, we need to do a systemic examination and a general examination. And then comes the investigations pertaining to whatever we have found out in the history and in the examination. Specific to anesthesia and very important is airway examination. So we need to do a detailed airway examination here. Once we have done all this, now comes the ASA grading. ASA grading is extremely important to an anesthetist, and it will tell us what is the risk the anesthesia will have on the patient. Next, in airway examination, we see in history whatever previous surgery the patient had, and if that during that particular surgery and anesthesia, any difficulty was encountered. So once you know if there was any difficulty encountered in the previous surgery and anesthesia, in the airway especially, we will try to be better prepared this time for the airway, and we will have our instruments ready, our supplies ready, so that any difficulty, any hypoxia during intubation and extubation can be avoided. Then we need to know whether the patient suffers from obstructive sleep apnea, that is OSA, and whether the patient is a nasal breather, has any tonsils or any other history which will lead to a difficulty in the airway. Any facial deformities that the patient has had, any previous surgery in the face that might lead to a difficult airway. Next, in examination, we need to assess for difficulty in two things. Now, these two things are difficulty in the mask ventilation and difficulty in intubation. For assessing these two things, we have multiple tests. We have multiple gradings that we need to know. All right. Now, in the examination of airway, there are a few distances that you need to know. Now, what are these distances? The first distance is inter-incisor gap. Now, what's an inter-incisor gap? It is also known as mouth opening. So what is that? You ask the patient to open his or her mouth with tongue protruded or tongue not protruded. Now, this is a trick question. It is when you're assessing for only inter-incisor gap, you do not have to protrude your tongue. All right, you just tell the patient to do ah, and you just assess the inter-incisor gap. So it is without protrusion of the tongue. All right. Now this gap is 3 fingers or 5 centimeters. If it is more than 3 fingers or it is more than 5 centimeters, it is termed as a normal inter-incisor gap. And if it is less than 3 centimeters or if it is less than 1.5 centimeters, you will have difficulty in your airway. All right, you'll have a difficulty in putting your laryngoscope blade inside the mouth. All right, now the next distance that we have is a thyromental distance, which is also known as Bartle's test. All right. So let me just show you what a thyromental distance will look like. You assess the thyromental distance from the thyroid to the mentum, which is your chin. So the thyroid to the mentum. How much is this distance? This distance is normally 7 centimeters. Okay. And if this distance is less than 6.5 centimeters, it is termed as abnormal and you will have a difficulty in airway. Another distance that is important is sternomental distance. Now, the sternomental distance, it is the distance between the mentum to the sternomanubri. All right. Now, this distance is 12.5 centimeters. Okay. And it is this single most important predictor of a difficult airway. Now remember, both the sternomental and the thyromental distances, these are measured in extension. That means you have to extend your head like this and then measure the distances. And you'll require a minimum of 2 scales to measure this. You put one scale over here, parallel to the mentum, and the other scale you put vertical, to whichever distance you want to take. And a third scale can be added to the lower point of either the thyroid or the manubrum where you want to take. So minimum 2 scales, up to 3 scales you will actually need. All right. Now, what is neck circumference? Now, neck circumference is the circumference around your neck, which is especially helpful to measure in obese patients, in patients who have short neck. They have the increase in the neck circumference of the neck because of the fatty tissues. Now, the fatty tissue does not only accumulate outside, it also tends to sometimes accumulate on the insides. All right, and will cause a difficulty during mask ventilation and during laryngoscopy. So, the neck circumference of more than 42 centimeters is abnormal. Now, we also look at the head and neck movements. Why? Because during laryngoscopy and intubation, we require a sniffing position. Now, what's a sniffing position? Now, a sniffing position is where you need flexion and extension. Where do you need the flexion? The flexion occurs at the lower cervical joints and the extension occurs at the atlanto-occipital joint. Now, let's see what does it actually look like. This is the sniffing position. Here you can see extension at the atlanto-occipital joint and flexion at the lower cervical joints. It's a very important question. Guys, listen to each and everything that I'm saying over here because not everything is mentioned in the slides, and the quiz that we have further, you might get answers in whatever I'm telling you rather than just in the slides. So be very careful over here. All right. Now, what does this actually do, the sniffing position? The sniffing position aligns which three axes? Anyone? Which three axes does the sniffing position align? Okay, so the sniffing position aligns the oral, laryngeal, and pharyngeal axis. All right, it aligns these three axes. Okay. Now, next thing, as I told you, we'll be taking up gradings. Now, two important gradings for you for your exam point of view are Malampatti grading and Cormack Lehane grading. All right. Can anybody tell me what does the Malampatti grade actually indicate and what does Cormack Lehane grading indicate? To which difficulty does it pertain to? Anybody? Okay, so the Malampatti grading or the MPG grading, it tells you about the difficulty in anybody? Okay, it tells you about the difficulty in mask ventilation. And Cormack Lehane, it tells you about the difficulty in intubation, in laryngoscopy and intubation. All right, so what is the MPG grading? MPG grading, it basically tells you about the size of the tongue with respect to the size of the oral cavity. All right. So how do you assess it? You look at the structures which are present in the mouth. You tell the patient to open the mouth and say ah, and with the you tell the patient to open the mouth and protrude the tongue. You don't tell the patient to say ah. Just tell the patient to open the mouth and say and protrude the tongue. Whereas we had done a previous grade, which was mouth opening or interincisor cap, in which you do not tell the patient to protrude the tongue. All right, so this is the difference here that you need to know, and this is very commonly asked in your MCQs. In which test you tell the patient to protrude the tongue, and which test you do not tell the patient to protrude the tongue. All right, so now what are the structures which we see in the Malampatti grading? In the Malampatti grading, we look at the tongue, the hard palate, the soft palate, the uvula, and the faucial pillars. We look at these structures, whether they're visible to us or whether they're not. All right, in the grade 1, all of them are visible. In grade 2, what is visible is the tongue, the base of the uvula, and the hard palate and the soft palate. All right, in grade 3, you see nothing but just the hard and the soft palate. In grade 4, you just see the hard palate and nothing else is visible. Now, can anybody tell me which grade amongst all these 4 grades indicates to be a difficult airway? It is grade 3 and 4. All right, grade 3 and 4 is difficult mask ventilation, and grade 1 and 2 will tell you a easy or a relatively easy mask ventilation. All right, now the next grade that we have to study is Cormack Lehane grading. Cormack Lehane grading, which I just told you, is going to tell you about the difficulty in laryngoscopy and intubation. Now, what is Cormack Lehane grade 1? Now, Cormack Lehane grade 1, it will tell you about your vision, about your visualization of the vocal cord when you do a laryngoscopy and intubation, direct laryngoscopy and intubation, remember. In this, you will be able to see the entire vocal cords with the anterior and the posterior commissure and the epiglottis also as you do the intubation. So it is a complete, beautiful picture of the laryngoscopic view, which you're going to observe. All right. In grade 2, you are going to see only the posterior 1/3 of your vocal cords. In grade 3, you're not going to see the vocal cords and you'll be just able to see the epiglottis. In grade 4, you'll be able to see nothing at all. Epiglottis is not visible. All right. Can anybody tell me which amongst these will be difficulty, will tell you that this is going to be a difficult airway? Anybody? All right. So grade 3 and grade 4 is going to tell you that it's a difficult laryngoscopic intubation. All right. And there is another modification here. Now, modified Cormack Lehane grading is grade 2A and 2B and 3A and 3B. Now, what is grade 2A and 2B? Grade 2A, these are modifications in the Cormack Lehane grading. All right. Grade 2A is where you can see the posterior 1/3 of the vocal cord with the posterior commissures. In grade 2B, you will be only able to see the posterior commissures. All right. In grade 3, what you'll be able to 3A, what you'll be able to see or do is you'll be able to see the epiglottis, and it will be liftable with your laryngoscopic blade. But in grade 3B, the laryngoscopic blade will not be able to lift the epiglottis. All right. So 2A, 2B, 3A, 3B, these are the modifications in your Cormack Lehane grading, which you should know. All right. And there's certain other indicators, and very important from your exam point of view is MPG0. Now, does anybody know what is MPG0? MPG0 is where you can also see your epiglottis. All right. You just tell the patient to open the mouth, and there are very special human beings and very special characters, which you just tell them to open the mouth, and you'll get a very beautiful epiglottis visible and hanging from the outside. Okay. And without the need for a laryngoscopic blade. There are other indicators as well, which will tell you about the difficulty in intubation or mask ventilation. Is any history of any obvious facial trauma that the patient has. All right. Buck teeth. Now, if the patient has buck teeth, you'll have a problem in hinging your laryngoscopic blade. All right. If the patient has beard, has a lot of beard, and sometimes due to religious purposes, patients will not shave their beard, even if you politely ask them to, because it is against a religion or certain other restrictions. So what we need to do in certain cases, because we'll encounter difficulty in mask ventilation, because it will not give a proper leak here. Air will constantly leak out when you give positive pressure ventilation. It will constantly leak out from the sides of your mask. So what we do in such patients, we put wax. We wax the beard, and it gets stuck to the face, and hence there'll be less air leaks. It's not going to be completely eliminated, but yes, comparatively, air leaks will be reduced. Certain obvious tumors that you can see, or the patient gives you a history of tumors of the oral cavity or of the face, you might again have certain difficulty in intubation, or any history of strictures. So you will have a difficulty in your laryngoscopy and intubation. And while putting a tube, you might need a smaller size tube. All right. Pregnant patients are also bound to have a difficult airway because of edema around the neck. All right, in the neck, they have a lot of edema. They have vocal cord edema as well. They have swelling of the larynx. So a smaller size tube is generally advised. In a normal adult, we use a 7.5 to 8 mm, 7.5 to 8 mm diameter. In adult males, we use up to 8 to 8.5, and females, we use 7 to 7.5. For a pregnant female, although we go for a smaller size, that is 6.5 to 7 millimeter in diameter. So this is something important that we need to know here. All right. Now, what are the syndromes that are associated with a difficult airway? This again is an important question from your MCQ point of view. There are certain syndromes like Pierre-Robinson's, Strecker-Collins, Downs, Klippel-Feil syndrome. So a few things you need to know about each of these syndromes, so that you know whatever difficulty you might encounter if you see such a child presenting to you in the pre-anesthetic checkup. For Pierre-Robinson's, the patient might have a cleft palate and macroglossia, which will cause you difficulty in both intubation and mask ventilation. Macroglossia will cause difficulty in mask ventilation. Cleft palate will lead to a difficulty in laryngoscopy. The blade sometimes gets stuck in the cleft. All right. Strecker-Collins, it's the patient have mandibular and malar hyperplasia. Down syndrome have macroglossia. They have an unstable atlanto-occipital joint, which leads to subluxation of this particular joint, and hence you need to be very, very careful during laryngoscopy and intubation. Klippel-Feil syndrome, they have a fused neck, again causing you difficulty during mask ventilation and intubation, because this is not going to extend properly. All right. Next. Now, what is difficult airway guidelines? Now, the difficult airway guidelines, whenever we are doing any case in the OT, especially elective case where you need to plan everything beforehand, you need to know whatever plan you have for your airway as well. We need to have a plan A, we need to have a plan B, and we need to have a plan C. Now, what are these particular plans? Now, by chance, we're not able to intubate any patient, another alternative plan needs to be ready. So the first plan that we have always is to mask ventilate the patient and then intubate. All right, do a laryngoscopy and simple intubation. But what if this fails? If this fails, a second plan, alternative plan needs to be ready, which is plan B. Now, this plan B is a supraglottic airway device. All right. Wherever possible, we put in a supraglottic airway, we ventilate the patient with that, and then constantly side by side think whether we can get the surgery done in the supraglottic airway device, or we need an alternative technique for it. We need a definitive tube or not to be put in. All right, so we can put the tube through the supraglottic airway device as well, or we can continue the surgery through the supraglottic airway device. If this particular plan also fails, then what we need to do, if this particular plan fails, then we take a final attempt and mask ventilation, and if it's an elective surgery, we will wake up the patient. We wake up the patient. All right. Because in an elective surgery, which cannot be done under supraglottic airway device, and in which we're not able to put in the tube, and we still need to patient to obviously survive, we will wake up the patient, and since the procedure is not emergent, we wake up the patient and explain the risks, whatever we encountered during our airway management, and then we plan the patient for next time. All right. And by chance, if even after going ahead with mask ventilation and we're not able to ventilate that patient, what we do is we go for a surgical procedure, that is cricothyroidotomy. We go for a surgical airway, and we put in a tube through the front of neck. All right, that's known as the front of neck access. All right, and we ventilate the patient through that. Now, this is an emergency. It will only need to be done if you cannot mask ventilate the patient. That is known as SICO. Cannot intubate, cannot oxygenate. We were not able to intubate. We are not able to oxygen or mask ventilate the patient. So oxygen is not going anyways. So we need to go from the front of neck. And if you're able to mask ventilate the patient, you can very easily wake up the patient. All right. So plan A is laryngoscopy and intubation. Plan B becomes your supraglottic airway devices. Plan C is your final attempt and then waking up the patient, or going ahead with your plan D, which is cricothyroidotomy. All right. Now, next is your ASA grading. Now, ASA grading becomes a very important part of your anesthesia risk stratification. All right. Whenever we take up the patient for anesthesia and surgery further, we need to decide what risk the patient has. So we have a classification by the American Society of Anesthesiologists, which is ASA grading, which is ASA 1, 2, 3, 4, 5, and 6. Now, very easy to remember is 1 and 6, which is 1 is a normal healthy adult patient, and 6 is a brain dead patient for organ donation. So 2 MCQs will be sorted from just this: a normal healthy adult and a brain dead patient. Now, what is ASA 2, 3, 4, and 5? 2 is a patient with mild systemic. 3 is a patient with severe systemic disease. 4 is a patient with severe systemic disease, which is a constant threat to life. And 5 is a moribund patient who will not survive without the surgery. All right. Now, you need to know certain examples here. Now, ASA 1 is a healthy non-smoker patient with minimal or no alcohol abuse at all. All right. Grade 2 is an occasional drinker, is a mild systemic disease which is controlled. For example, hypertension, diabetes, which is controlled. An obese patient with a BMI of more than 30. Somebody who is who drinks but is only occasionally. All right, a social drinker, that is known as. So that is grade 2. Grade 3 is a patient with severe systemic disease. All right, so an uncontrolled diabetic or hypertensive patient will come into grade 3. All right. And a preterm child with post-conceptional age of less than 60 weeks will come into grade 3. Patients with history of TIA or coronary artery disease or an MI with more than 3 months will come into, again, grade 3. With less than 3 months, they will go into grade 4. So this is one differentiation that you need to know, grade more than 3 and less than 3 months. All right. And patients who are on end-stage renal disease with dialysis will come in grade 3. Without dialysis will come in grade 4. All right, because that is a systemic disease which is a constant threat to life. Okay, so these are a few examples that you need to know with differentiations. BMI with grade less than 40, but more than 30 will come in grade 2, but more than 40 will come in grade 3. So this is another differentiation that you need to know, and this is also an MCQ question. All right, in grade 5, somebody who needs the surgery urgently, without which the patient is not going to survive, will come in grade 5. For example, somebody with a perforation peritonitis, all right, somebody who has an ischemic bowel, somebody who is planned for aortic aneurysm, all right, ruptured aortic aneurysm, without which the patient is not going to survive. So that will come in grade 5. You need to know the examples very clearly again, because these are asked in your MCQ. Very important, one thing is not mentioned here are pregnant patients. Okay, so pregnant patients, which grade, anybody? It's going to be grade 2, ASA grade 2. All right. Now let's come to the pre-operative orders that we need to put in for the patient before taking up the patient for surgery. There are a few important pre-operative orders that we have to put for all patients, like written informed consent, very important, nil per oral orders, and anxiolytics, anti-aspiration prophylaxis. All right, so we'll see in which patients we need what kind of anxiolysis, what are the anti-aspiration prophylaxis that we need to give, and to which category of patients. Now, what are the nil per oral guidelines? There are certain guidelines that you need to know, which is 2 hours, 4 hours, very simple to remember, 2 hours, 4 hours, 6 hours, and 8 hours. All right. Now, clear liquids can be taken up to 2 hours prior to surgery. Which are these clear liquids? Like water, a juice without pulp, green tea, that is a clear tea, or absolutely black coffee, carbonated beverages, which do not have any particulate matter in them. Breast milk, it can be taken up to 4 hours prior to surgery. Formula milk can be taken up to 6 hours prior to surgery, and a light meal can be taken up to 6 hours. A full fatty meal can be taken up to 8 hours prior to surgery. So for 8 hours fasting, a fasting of 8 hours is needed for full fatty foods, all right, to prevent aspiration in patients. All right, now anti-anxiety or anxiolysis with sedation and amnesia is provided by benzodiazepines. So sometimes we also prescribe benzodiazepines prior to surgery. Anti-aspiration prophylaxis is given in certain high-risk patients like pregnant patients, diabetic patients, in whom we have risk for aspiration. Why do we have risk for aspiration in diabetics? Anybody? Now, any guesses? Okay, in diabetics, we have decreased motility because of autonomic disturbances. There is a decrease in the motility of the intestines. Okay, and why in pregnancy? Anybody? It is important to know. Now, in pregnancy, what happens? The pregnant uterus, it pushes the diaphragm up. All right, it pushes the diaphragm up. So there is an increase in the intra-abdominal pressure and the intrathoracic pressures. All right. Also, what happens is there is an alteration in the angle between the esophagus, that is the lower esophagus, and the fundus. All right. So more amount of regurgitation keeps happening. Thirdly, there is a decrease in the lower esophageal sphincter tone. Because of which hormone? Anybody, any guesses? Again, an MCQ exam question. It's because of progesterone. All right. So you keep having regurgitation and dyspepsia in pregnant patients, and hence, obviously, the risk for aspiration during general anesthesia. Now, what are the anticholinergics that we prescribe prior to anesthesia? And why do we prescribe them? Now, anticholinergics that we prescribe are glycopyrrolate, atropine, and scopolamine. All right. Now, which has advantages over which one, and why do we give them? The most common that we prescribe in preoperative period is glycopyrrolate. Now, glycopyrrolate is given in a dose of 0.01 mg per kg. What it does is it decreases the secretions. All right. Because if there are more amount of secretions, we'll have difficulty, one, in your airway management, because it'll keep pooling. Secondly, it will cause spasm and irritation of your airways. It can lead to broncho and laryngospasm. All right. So we avoid having secretions in our way, and that's why we give anticholinergics. The other anticholinergics that we give are atropine and scopolamine. How do they differ from glycopyrrolate? Atropine and scopolamine, they tend to cross the blood-brain barrier. So they have a common side effect, which is sedation. All right. So, but glycopyrrolate will not cause that because it is a quaternary ammonium compound and will not cause sedation. Okay. And will not cross the blood-brain barrier and hence will not cause which side effects? CNS side effects. Okay. Now, we also need to manage if the patient was on any previous medications. We need to see whatever previous medications the patient was taking. All right. And we will need to alter the medications in a way. We will either continue them, we'll write orders for continuation of those medications, one, or we will ask the patient to stop the particular medication, or we might even put the patient on another medication. All right, an alternative therapy. Okay, so first comes oral hypertensive. Oral hypertensives are to be continued up to the day of surgery. All right, you do not ask the patient to stop because we do not want any fluctuations in our blood pressure control. All right, because any alterations in your blood pressure control will lead to difficulty during your anesthesia. It will cause fluctuations in your blood pressure, it will cause fluctuations in your heart rate, and will lead to adverse outcomes, which we do not want to increase. All right. Next come your antipsychotics and antidepressants. Antipsychotics and antidepressants and anti-epileptics as well. They're all continued throughout your preoperative period. All right. Except for two drugs, lithium and tricyclic antidepressants. Now, lithium, you have to stop lithium up to 24 to 48 hours prior to surgery. And TCS, you have to stop 3 weeks prior to surgery. All right. Hormone replacement therapy is to be stopped 4 to 6 weeks prior. And herbal medications, they are also to be stopped 4 to 6 weeks prior. Now, an important thing about is over here, you need to know about is OHAs, that is oral hypoglycemic agents. Now, oral hypoglycemic agents, you have to omit the morning dose of that particular drug. And you might even take the patient up on insulin. Why do you take the patient on insulin? You take the patient if the patient is undergoing a major surgery. Minor surgery you don't require, but during a major surgery, because of increased stress hormones, you would like to start the patient on insulin. All right. Why do you stop OHAs? That is the morning dose. Why do you omit that? You omit that to avoid any hypoglycemia. All right. Now comes clopidogrel and other anticoagulants. Now, clopidogrel is stopped 5 to 7 days prior to surgery. Warfarin up to 3 to 4 days prior. Ticlopridin is stopped 14 days prior. And low molecular weight, we have two types of therapies for low molecular weight heparin. One is therapeutic and the other one is prophylactic. So which one for prophylactic and which one for therapeutic? Over here, I have mentioned two timings. Can anybody tell me? Okay, for prophylactic dose, which is a once daily dose, we can give up to 12 hours prior to surgery. And for a therapeutic, we need to stop it 24 hours prior to surgery. All right. Factor 10 inhibitors, 48 to 72 hours prior. Aspirin, two types, low dose and therapeutic dose. Again, low dose is, we can continue it very easily. That is 75 mg. And therapeutic dose, we stop it 7 days prior to the surgery to avoid any untoward effect or any bleeding during the surgical procedure or anesthesia. All right. And what about stents? We have two types of stents. One is bare metal stent and drug-eluting. Bare metal stent, we avoid an elective procedure because of anticoagulation continuation up to 1 month. And in drug-eluting, we avoid an elective procedure up to 1 year. Okay. Now let's come to an important syndrome over here, which is Mendelson syndrome. We have been continuously talking about aspiration a lot and anti-aspiration prophylaxis a lot. Now, what is Mendelson syndrome? Mendelson syndrome is nothing but chemical pneumonitis. Mark my words, chemical pneumonitis. All right, it's again an exam question. Chemical pneumonitis, which is caused by aspiration of gastric contents into the airway and the lungs. All right. So what happens is, whenever there is any patient, like a pregnant patient or a diabetic patient, in whom there is higher risk for getting aspiration, these particles or these gastric contents, which are higher in volume and less in pH, they trickle down and cause a bad airway or a bad chest. All right. And because irritation of the chest, of the lungs and the airway. It happens when you have a gastric volume of more than 25 and a gastric pH of less than 2.5. It's more acidic. So what happens? The patient develops cyanosis, tachycardia, hypotension. The patient might even go into pulmonary edema, and the lung compliance, as I said, a bad chest, that means the lung compliance is going to reduce, and the patient will develop metabolic acidosis. All right. So these are the things that happen. Also, what you need to know here is prevention. How do you prevent it? We've read it very recently, just a few minutes back. NPO guidelines you have to follow, nil per oral, especially in diabetics, in whom you advise them to go for nil per oral 8 hours prior to anesthesia. All right, to prevent aspiration, because they have decreased motility in their intestines. Next, we will like to increase the pH. As I told you, if you have a lower pH, less than 2.5, you will have more chances of getting it. All right, so you tend to increase the pH. How? You give PPIs, that is proton pump inhibitors, ranitidine. Okay, and you tend to give a non-particulate antacid. Which one is safe in pregnancy? Rantac, and an antacid you can give. These are the safer ones in pregnancy. All right. Next is you can decrease the gastric volume as well by increasing the motility. You prescribe metoclopramide, which is very, very commonly known as, anybody, any guesses? Yes, Perinon. All right. Now you also have to weigh about the pros and cons of regional anesthesia, but the risk-benefit ratio of regional and general anesthesia. Whenever deciding for a patient with a high risk for aspiration. If you can give a regional anesthesia very easily in that patient, we prefer that, right? Then we also prevent it by doing RSI. If you have to give general anesthesia, we do rapid sequence induction in this patient, all right? We'll come to rapid sequence induction in the next slide. Before that, how do you treat if you get Mendelson syndrome? You put the head low, all right, so that whatever secretions and whatever food particles have come up, they will pull down into your oral cavity and will not go down further into your chest, all right? And we suction all the contents out of that area where the contents have collected, and we give cricoid pressure so that no further contents can go from the esophagus into the oral cavity and further down into the trachea. And if the patient is still worsening, loses consciousness, or has creps in the chest, we tend to intubate the patient and give 100% oxygenation with positive pressure ventilation. There is a role of PEEP here, which is peak end expiratory pressure. And we give that so that we do not, the patient does not develop atelectasis or collapse of the smaller airways. All right, this is very important. What is again important here is an MCQ question, whether Mendelson syndrome or this chemical pneumonitis, as it is known as, has a role of antibiotics. No, it does not have a role of antibiotics per se, until and unless there is secondary infection development. Also, there is no documented role of steroids, although very commonly given to a patient. But as such, it's not in the recommendation, might help in a patient with Mendelson syndrome. All right. Now, what is rapid sequence induction? Now, this rapid sequence induction is done in a patient who is at risk for aspiration, has a full stomach, or pregnant patients, all right, a patient who has intestinal obstruction. All these patients are candidates for rapid sequence induction. Now, there are a few components of rapid sequence induction that we need to know here. The basic component here is that you apply pressure on your esophagus. You compress the esophagus against your spine, that is the vertebral column, with trachea in front. All right, the trachea is in front, then you have your esophagus, and behind you have your spine. So you compress the esophagus so that nothing trickles down from your esophagus into the airways. Now, how much pressure do you give? You give about 10 to 30 newtons, or just enough to blanch the skin of your thumb. That is how much pressure you give. All right. Another important component here is not to do any bag and mask ventilation or a positive pressure ventilation until and unless you have a tube in place. All right. So you don't do a positive pressure ventilation here. Important here. Then the steps that you need to do is you lay the patient down on the OT table, attach all the monitors, then pre-oxygenate the patient with 100% oxygen. All right. Now, this pre-oxygenation can also be done by two methods. Now, you can either give tidal volume breaths, all right, or you can do vital capacity breaths. You can give 8 vital capacity breaths with 100% oxygen, or you can do tidal volume respiration for 3 to 5 minutes with 100% respiration. So these are the two components. Okay. So you pre-oxygenate the patient, you give a predetermined dose of induction agent to the patient with scoline. In modified RSI, you can also give rocuronium with a dose of 1.2 mg per kg. Then we apply cricoid pressure in the front of the neck at the cricoid cartilage, which is also known as Sellick's maneuver. This is definitely different from the pressure that we give while improving laryngoscopic view, which is known as burp. So this is the differentiation here. And then we intubate the patient. Okay, you might incur certain difficulty while intubation because of the pressure that we apply on the front of the neck, but it is essential to be done with this particular view. You can loosen it up a little just before if you're not able to visualize the vocal cords properly. Okay, but again, and it's an essential component of rapid sequence induction or intubation. What is pre-oxygenation? Pre-oxygenation methods I've told you. How do you pre-oxygenate a patient? It's also known as denitrogenation. It's basically the replacement of all the nitrogen which is present in your functional residual capacity with 100% oxygen. What it does is it increases the apnea time. Okay, it increases the apnea time from 2 minutes to 8 to 10 minutes. So the patient does not desaturate at that time while you're doing laryngoscopy and intubation. You're not providing any oxygen to the patient at that time. Okay, now this is done in those patients where you have a difficult airway, anticipated difficult airway before RSI, in obese patients, in pregnant patients, in patients who have an increased demand of oxygen like sepsis. So these are the candidates for pre-oxygenation, and do not do it in all cases. All right, it's not done routinely. It's because 100% oxygen is as it is harmful, even though we give it for a very short period in pre-oxygenation. So you avoid it in all normal ASA1 healthy patients. You only do it whenever required. Okay, now let's come to our quiz. All right, before coming to the quiz, remember we have a very special question in the end as well. So I hope you remember everything that I have just taught you, and Nextillo has come forward in teaching you this particular topic. Hope it's thorough, and let's begin with our questions. The first, as you have seen, I just showed it to you, it's an image-based question here. So which Mallampati grade does the patient fall into? Any guesses? Okay. What can you see in this picture? Can you see the hard palate? Yes. Can you see the soft palate? Yes. Very good. Yeah. All right. So you can see the hard palate and the soft palate, and the uvula is not visible. All right. So this will fall into the category 3. Okay. Now, difficult laryngoscopy grading. Which one of them? MPG grading, CL grading, Bartle's test, Sawa's test. Any guesses? We've just done it here. So difficult laryngoscopic grading is CL grading. Yes. So option 2 is the correct option here. Difficult bag and mask grades. Which amongst them is a difficult bag and mask ventilation grade? Any guesses? Is it MPG3? Is it MPG4? Whether it's both of them, whether it's none of them? Yes, it's both of them. MPG grade 3 and 4 is for difficult bag and mask ventilation, and CL grading 3 and 4 is for difficult laryngoscopy and intubation. Great. Okay, so I have already, I think, told you the answer. Difficult laryngoscopic grade, grade 1, 2, 3, or none? Yep, it's CL grade 3. Great. Now, let's come to pre-oxygenation, something that we've just read recently. Pre-oxygenation is done in all ASA1 patients, whether it's done in pregnant patients or anticipated difficult airway or B and C. Anybody? Okay, so it is both B and C, pregnant patients and anticipated difficult airway patients. Okay, great. Now, let's come to the question of the day. Now, Selleck's maneuver is also known as cricoid pressure, burp, both, or none. It is also known as cricoid pressure. Burp is very different. Okay. Now, burp is backward, upward, and rightward pressure. It is not cricoid pressure. It's different from that. Okay. Now, burp is done to improve the laryngoscopic view. Okay. And whereas Selleck's maneuver is done in rapid sequence induction or rapid sequence intubation to prevent what? Anybody? To prevent aspiration. Okay. Great. With this, we conclude our session today here of pre-anesthetic checkup in anesthesia. All right. And this was the first topic. I hope all the topic is thoroughly clear, and whatever doubts you might have had before about pre-anesthetic checkup are now clear. All right. Okay, great. It was great taking this session. Bye-bye. Have a good day.